Okay, we will get started. Welcome to our Vital Insights webinar on care transitions through the lens of malpractice claims. We've got a few more folks joining us, but I'd like to introduce myself. I am Val Frankfurt with Coverys, and we appreciate you joining us for this important topic today. We have three experts in the area of care transitions for our panel discussion. From Coverys, we have Bob Hanscom, who's our Vice President of Risk Management and Analytics. Bob leads our enterprise with risk management services, data quality, and data governance. Anne Fiala from Coverys, she's our Senior Risk Specialist. And Anne has more than 30 years of experience in quality, regulatory readiness, and patient-centered care. And we're also very excited and honored to have an expert in the trenches, and that's Ilda Demidros. She is an RN with Community Care Cooperative, Mass Health, ACO. Ilda serves over 125,000 members across Massachusetts at 18 health centers. She has over 30 years experience in healthcare and over 15 years specializing in care transitions for both pediatric and adult patient populations. We do have one request. If you have questions during our panel discussion today, if you could please put them in the Q&A tab at the bottom of your screen, and our panelists will then answer them, as many as possible, during our 15-minute Q&A session at the end of the discussion. So Ilda, I do know I slaughtered your last name. Apologize, you can correct me on that. But
No problem.
Bob, I will hand it over to you.
All right. Well, thank you, Val. And again, welcome from me as well. My name is Bob Hanscom. And as Val indicated, I'm the Vice President of Risk Management and Analytics at Coverys. I've been with Coverys for 8 years. And I'm responsible for our risk management operations, for advanced analytics, and for enterprise-wide data quality. So before we go into these data slides, I just want to kind of give you a bit of background about us. At Coverys, we've developed our own comparative benchmarking database, which captures and codes the deeply rooted drivers, the causation factors underlying our malpractice claims. We are using this data and associated analytics to anchor a predictive and proactive approach to managing risk, with the goal of helping providers, practices, and hospitals fix their vulnerabilities before, not after, harm reaches the patient. But we are doing other things with our data. We are publishing on it. We are just now releasing our latest report, Care Transitions Through the Lens of Malpractice. Earlier reports had focused on medication error, on failure to diagnose, obstetrics, and emergency medicine, just to name a few. Late last year, we produced a 10-year trend report to take a close look as to whether or not there had been any significant improvement in our key target areas over the past decade. This latest report is a little different from the rest. Transitions in care happen repeatedly with every patient, every hour, in myriad ways in the routine delivery of healthcare. Most go very well. There are processes, disciplines, communication channels that are all well-defined and adhered to. But we also know that patient transitions, whether it's from one provider to another, one place to another, one specialty to another, there are vulnerabilities. We had never really seen a full study on this before, so we decided we would try to identify those cases where the transition in care was the actual cause of an adverse outcome. It took some work to find these cases because most malpractice claims had other causation factors that were much more dominant, even though there are transitions in care pretty much every direction that you look. But in the end, we were able to zero in on 210 malpractice cases where the transition in care was the primary problem. Let's see here, let me move my slides. So just want to talk about methodology. Before I go into some of the data, I want to quickly talk about methodology. We have often found that just reporting out on data in problem areas and these malpractice cases is simply not enough. What is needed is a methodology to make those findings actionable. So this is ours. We use our claims data as signals. And the reason why we call it signals is because claims data has a lot of limitations to it. Most notably, of course, it's a pretty small n, so statistically, is it significant? That's the first one. The second one, it's always a look to the past. And the third one is that you often see very unique convergences of factors. So it's hard to know if, in fact, it's ever going to repeat itself in exactly the same way. But yet, we know that these are signals that providers, practices, hospitals should be paying attention to. So what we do is we essentially feed our risk assessments with these signals. And it's really asking the question as we're assessing risk, are those factors still at play in today's environment? In other words, is the signal strength from the claims data weak? Is it moderate? Or is it strong? And if those factors are still at play, often we will declare that, in fact, the signal strength is strong on particular factors. Once, in fact, we have determined that those factors are still at play, that really leads us to prioritizing with our clients, our constituents, responsive solutions, whether that's in education and learning, whether that's in implementing new models, whether there are best practices out there that are highly responsive, but that's really following what we are already describing as the trail of evidence here. And then ultimately, what we try to do is we try to help our constituents look for indicators that can be measured in the real time that will show that, in fact, there is progress being made, because that's where we can start saying, look, given everything that's been done to respond to these vulnerabilities, if there is improvement in the real time, that can be predictive of, hopefully, a reduction in malpractice claims further down the road. So if this methodology is followed, it ties in that past, those signals from the past, to what we can do in the present to really make sure that, in fact, we're going after safer and a more highly reliable form of care. So let's look at these transition in care cases. So first of all, we're going to look at allegations. And as you can see from this particular diagram, with the red bar being frequency and the blue bar being indemnity paid, these largely result in diagnosis-related allegations. So that's really the first category. 42% of those 210 cases, those 210 events, were related to a missed or delayed or a failure to diagnose. And you can see that that 42% resulted in much higher indemnity dollars that were that represented payouts on these cases, whether by settlement, jury trial, or any other means of payout. The next one down, of course, you can see the next category down is medication related. Behind that, slightly behind that is medical treatment. Behind that, surgery or procedure related, and then OB, and then finally patient monitoring and anesthesia related. Let's also look at diagnosis. Let's really try to do a bit of a dive in. With diagnosis being such a large category, definitely needs some breakdown here. So what are the conditions? Well, you can see that, again, these transition and care cases turned out to be 50% of them missed or delayed cancer diagnoses. Cardiovascular was second at 20%, infection at 11%, 7% were neurological. But cancer, of course, the big headline here with these particular cases. And again, the diagnosis cases were 88 out of the 210. You can see with the little footnote at the bottom. Let's move on to injury severity of these cases. These are high tragedy events. If you put the 45% that you see at the top that resulted in death, together with the 14% that are high severity injury, it means that 59% of these cases had very, very bad outcomes. They also represent a cumulative total of 66% of the indemnity that was paid. So these are very, very serious cases. Again, it's not a huge number, 210 cases, But you can see that, in fact, this snapshot is one that really is high tragedy for patients and patients' families. Let's look at the top specialties. And these are grouped into general categories, but general medicine is the leader here. 26% of the cases were with general medicine, representing 23% of the indemnity dollars. 22% were general surgery and surgical subspecialties, representing 30% of the indemnity dollars. 15% were emergency medicine, representing 11% of the indemnity dollars. Now, this slide is a little busy, so you have to bear with me on this one. So what are the top locations? The upper circle, if you can look, just center your eyes on the middle of that, are the percent of events. So that's frequency. The bottom circle is essentially the indemnity dollars. So what's the percentage of indemnity dollars? We essentially have three different camps. One is transitions of care to external either locations or providers. The second one is office to office, and the third one is strictly internal. So internal within a hospital, internal within a particular entity. You can see at the top that 61% of these transition and care scenarios were to external, were what we call external. And that represented, bottom graph, 45% of the indemnity dollars. 14% top were office to office, representing 22% of the indemnity dollars. And then 25% were internal, representing 34% of the indemnity dollars. And you can see what we mean by external. If you can read what is written there, it's a little bit hard to see, but when we say external transitions, we're talking about, for example, inpatient to rehab. That's one of the ones we regard to be external. Inpatient to home, that's probably pretty obvious to people. Emergency department to home. Inpatient to office. So it's one setting to another that is not office to office, and it's certainly not internal either. Emergency department to office, and then finally outpatient surgery to home. So those are some pretty clear examples of where some of these external transition and care problems were rearing their heads. So now let's look at the risk management issues. And again, a busy slide, but I'll quickly go through this. What are the risk management issues in these 210 cases? Well, first of all, the 210 cases actually allowed us to find 563 risk issues, and that's not surprising. There's often 2 to 3 risk management issues with any given malpractice related scenario. So we were able to capture these and code these. But you can see that clinical decision-making was the top category here, 29%, followed by clinical systems, 27%, followed by communication at 11%. And then behind that were a number of other categories that you can see here. But what do we mean by clinical decision-making? Well, you can see, again, some of the categories, some of the subcategories that we were able to capture and code here. Lack of integration of family or personal history into decision-making, negligent post-op monitoring and or treatment, failure to obtain a consult or a referral, inadequate or inappropriate testing, narrow diagnostic focus, and a failure to rescue. So that's what we mean when we're talking about clinical decision-making. Clinical systems, what do we mean? Well, results in or specimens that are lost, misfiled, or the MD was somehow unaware of the results, a lack of coordination of care, failure or delay in following up or in notifying of incidental findings, failure to manage the patient's follow-up care, premature discharge, failure to inform patient of test results, failure to promptly review test results. And then finally, under communication, some fairly broad categories here, but this is where we see the issues coming up. Physician to physician interaction. So somehow the message was lost between MD to MD in terms of the care of the patient. Physician to nurse interactions, phone or email treatment of the patient, and then finally physician to patient interactions. So let's just look at a few more slides here. We always want to look at the percent of cases that are closed with indemnity paid. That gives us kind of an indicator as far as whether or not there was truly liability. Not a perfect indicator, but one of the ones that we always follow. As you can see here, for all other cases, cases closed with indemnity paid, at least in the Coverys database, 28%. But when we looked at these care transition cases, 59% were closed with indemnity paid. So in these cases, there was a much higher percentage of cases where there was really, where the standard of care was potentially questioned, where in fact there felt as there was a belief or an opinion that there was liability, and ultimately that led to some sort of payout. And you can see that's much higher. The average indemnity paid, you can see on these cases, $584,000 compared to the average for all other cases, $453,000. And then the one kind of last area that that we want to look at here, or close to the last, are where care ends, where care begins and where it ends with these transition events. So you can see it with 84% of these, essentially, they originated in 4 locations. And those 4 locations were the inpatient room, the emergency department, the physician office, and the OR. Where they ended, 64% of them ended in the patient home, the physician office, or the inpatient room. So just kind of a snapshot of kind of where they start and where they end, at least looking at these 210 cases. We also want to look at patients that have comorbidities. We do firmly believe that patients with comorbidities seem to be at greater risk when transitioning care issues emerge. And as you can see, 52% of the patients involved in these scenarios had at least one comorbidity. It's not really a surprise, because they are inherently at higher risk. And when failures occur during these transitions, they may be more prone to higher injury outcomes. And then finally, vulnerable age groups, perhaps not a huge surprise here, age less than 25, 13% of these cases. The big category, 25 to 64, 57% of the cases were there, which again may follow more of the population demographic here. But I just want you to take a particular look at the 65 plus age group, that's 30%, and just take note of what we've written there. 73% of those cases of events involving seniors resulted in high injury severity or in death. So that, again, a great deal of vulnerability with those with the senior group, with those patients who are particularly vulnerable because of their age. So with that said, I am going to now hand it over to Ilda and ultimately to Anne. I know that Ilda has had a chance to review and to really comb through our latest publication. I know she has a good number of thoughts as far as transition and care issues. So Ilda, please take it away.
Thank you so much, Bob. And thank you so much to the Coverys team for having me here today. And I also want to extend a thank you to a dear friend and colleague, Amy Bailey, one of the participants today. My name is Ilda DiMedeiros, and I've been an RN for close to 30 years and in healthcare leadership over the last 20, of which for the past 15, specifically in the care management and transitions of care arena. I'm currently the Director of Care Management and Care Transitions for an accountable care organization in the state of Massachusetts, primarily supporting a Medicaid patient population. I've worked in the medical inpatient sector where I helped support several key transition points from emergency departments to inpatient bed units, from medical surgical units to ICU levels of care, and fortunately, many patients back to home or home with home health care services. not to mention many discharge plans to skilled nursing facilities, acute inpatient rehabs, and long-term acute care facilities for all patient age groups, pediatric to elder adult. I have done so from the inpatient bedside, as well as from the insurance payer perspective for an international and global health insurance carrier. From the pediatric to adult to elder patient populations with varying medical and behavioral health diagnosis, really one true question remains. How do we provide the safest and highest quality care to those we serve? And lately, we cannot ask this question without also asking about the total cost of care. We're all adjusting to being asked to do more with less. And how do we guarantee that the safest, highest quality care delivery will continue as it transitions from our hands to someone else's? That's what we're here to talk about today, minimizing risk through care transitions. It boils down to much, but one word really stands out: trust. We, our loved ones, our patients, their loved ones, they count on us as healthcare providers to deliver the highest quality and safest care possible. When we walk into a provider's office or a hospital, perhaps take our loved one or our child, are we seeking C-, D+, or A+ care? They expect that from us, as they expect it from every individual they interact with during their healthcare journey, that we will all deliver A+ care. Such healthcare journeys can be as simple as visiting a PCP's office, perhaps a specialist clinic, a local pharmacy to pick up a new medication. With every interaction, again, our patients expect and deserve A+ care. We strive to deliver A+ care. Is the premise simple? Yes. Is it easy? No. Our reality, what is it? The reality is that we are a rather complicated, convoluted, and let's be honest, quite often a short-staffed industry. And to complicate matters, in February, March of last year, the unexpected occurred, a word that probably many of us didn't think we'd ever hear in our lifetime: pandemic. That has only complicated matters more so. So far, I've spoken a bit about the premise of healthcare. I haven't even gotten into the technology aspect of it. Though we've made incredible advances in healthcare technology, both on the diagnostic and documentation end, we are challenged with the fact that many systems don't speak to one another. In the middle of all of this are humans facing, likely, the greatest challenge in their life: a moment of illness. I've had the opportunity to read Coverys's white paper on care transitions through the lens of malpractice claims, and thank you, Bob and Anne, for letting me have one of the first glances at it. If you have not yet had a chance to read it, I encourage all of you to do so. The focus is clear. It's what we're all after, the triple aim: better care, better health, and lower cost through improvement. There are many things that resonated with me, and some of them Bob has already covered, but the top 4 were that 80% of serious medical errors are caused by ineffective care transitions. That concerns me greatly, especially in my role having run care transitions team over the last several years. Claims stemming from care transitions, again, are 29% more costly than claims arising from other allegations. And external transitions, when patients leave our service and we transfer them out, account for 61% of errors. And the top risk management issues 29% related to clinical decision-making, followed by a close second, 27% related to the clinical systems. And I know that Bob just went over those. So how do we mitigate such errors from occurring? I encourage you, when you receive it, to read page 28 of Coverys's white paper, Managing Risk and Improving Patient Safety. The following are my personal professional golden nuggets, having been in this work for some time. I can't say enough about communicate, communicate, communicate. You can never communicate enough. Document, and I could probably reiterate that 3 times as well. Document, document, document. Day 1 of healthcare education. If it's not documented, it's not done. And document as much as possible in real time. Involve your patients, their significant other, family. Guide them to make the best decisions possible. Don't just make decisions for them. Give them all the options. Don't make promises. Often things can change, and when expectations are set and we don't deliver them, we can easily lose a patient's trust. Follow through. Get back to patients with updates, even if it's no update. Same goes for transition care points. Follow up with a skilled nursing facility, for example, if a patient is held up on a unit because of an ambulance transport delay. Don't assume anything. Be clear in your delivery and always leave an encounter with, is there anything else you'd like to know? Can I answer anything else for you? And educate. And not only patients and their loved ones need education. Sometimes other colleagues, despite their education and knowledge level. Gather and study your data. Bob just spent a good amount of time presenting us a wealth of information, what Coverys refers to as signal intelligence. Data is everywhere. If you are not privy to have your own data analytics team, whatever care setting you're working in, ask for it. Study your trends. Be prepared to avoid the avoidable. Standardize your workflows and work practices. Standardization is key to minimizing errors. It allows for consistency in your practice and makes it a lot easier when you train and onboard new staff. And last, be honest and upfront when you don't know. Share your vulnerability and be willing to learn. There are no easy answers, but as we gain knowledge about known errors and how to avoid them, we can ensure safer care delivery, thus ensure trust in healthcare. So thank you again for your time. And again, thank you to the Coverys team for having me. I'm open to questions.
Hilda, before we hand it over to Ann, there are a couple ones that I wanted to just follow up with you on. The first one is the whole notion of standardization. And certainly during my career, as I've talked with clinicians, particularly doctors, about standardization, there's been a bit of a negative reaction to that somehow you're asking us to do something that is actually not appropriate for medicine. And I guess what I like to do is just kind of maybe get a balance on this one, because I do believe that, in fact, healthcare has been overdue for standardizing key processes. And of course, as we're looking at transition and care issues, you can see where those key processes, weren't standardized and care fell through the cracks. So just kind of give us maybe your take on where we need to really start heading in terms of this word standardization and how it really needs to perhaps make more of a headway in healthcare.
Yeah, thank you for the question. So we know, and depending on whatever your practices are, If you're a PCP provider who's got a wide panel of patients, perhaps you see pediatric patients, perhaps you see teenagers, adults, and elders. And I guarantee you that each of those patient groups are covered by different insurance carriers. You have the insurance carrier, the commercial members, right, who come in because they're well employed and they have insurance through their employer. You may have a patient population that is supported by your state Medicaid plans. For example, the work that I'm doing right now is supporting a Massachusetts-based Medicaid plan. Members receiving care across community health centers across our state. And obviously, we have elder patient populations that are covered under Medicare. The patient is indeed the variable, right? We know that not all members that walk in with CHF or COPD, diabetes, or perhaps a behavioral health diagnosis are the same. They're coming in with unique challenges, right? Different comorbidities. But if we standardize our practices, how we take them through the care delivery of walking through a PCP's office, walking through an emergency department, admitting them to a hospital unit, and then definitely the transition to the next level of care, if we standardize those practices according to the National Patient Safety Goals, and there are, NCQA, the National Quality Assurance Commission, definitely puts out national quality safety goals. We should all be following those. For example, that every patient that goes through a transition, regardless of age group or insurance coverage, receives a medication reconciliation as we're transitioning care. So that's what I mean about standardizing as much as possible. And certainly a challenge that we've faced, that I've faced in my career, having worked with members that are covered by commercial plans, Medicare plans, and Medicaid plans. And for example, as an ACO, we're walking into a health center to try to get them to standardize and optimize care, transform their practice for the better. And all of a sudden they're noticing, we shouldn't just do this for our Medicaid patient population. Let's do it for our commercial members and our Medicare members as well, and deliver high quality care across the board. So I hope that answers your question, Bob.
Oh, it does. One other comment, and then Ann, I'm sorry, I'll let you follow up here. But you know, I was really pleased to hear you really emphasize the notion of documentation, and do it in a way that actually is the correct way of doing it. Often when we talk about documentation from the medical professional liability perspective, the way it's interpreted is that people are thinking that we want providers to document so we can better defend them should they be caught up in a lawsuit. And that definitely is a true point. If they're in a lawsuit, we can't really defend them unless, of course, it's somehow in the record as far as what they were thinking and what sort of care plan they were really pursuing. But you emphasized documentation related to this, which is, you know, in order to make sure that, in fact, we are really ensuring continuity of care and we're not having these transition and care issues, documentation is a key piece of that. It's a key ingredient of that. And I think that's really important for emphasis here. It really, I think, kind of shifts it away from doing it just because you want to be in a good place if you get sued, to this is something that is really critical for safe, highly reliable care. And I think that's the way you were really
Absolutely. Yeah, it really is key. And I can't say enough about, we're all busy, but as best of real-time documentation is always best, because if ever an adverse event was to occur, they're gonna go right for the medical chart, right? Right today, technology, it's an electronic health record. It's stamped real time today at this time. If you start backlogging some of your documentation of perhaps the care that you delivered yesterday, this morning at 11 a.m., we're human. We're probably going to document with a sense of covering ourselves, right? Let's be honest. So as much of real-time documentation, and I know that some of the cases that you pointed out in the case examples in the white paper clearly demonstrate how missed documentation and missed communication led to some real unfortunate circumstances.
Good. Anne,
Yes,
take it from here.
I have the honor of kind of pulling this all together and talking about some of the risk implications and some recommendations we have. This paper was written as a labor of love. I think it took us a year and a half to actually get it from there to here. And through that whole process, we really did a lot of digging and soul searching and reviewing case studies. And I have to say that one of the hardest parts about the paper was the case studies, just to see what actually happened. These are people. These are people with family and lives. So if you guys haven't read the paper, I would strongly encourage you to do that and take a look at these case studies, because they do tell the story of what happens when things aren't done properly. What I'd like to talk about really are some risk recommendations. And again, you can find all of these in the paper. I'm just kind of highlighting some that stood out to me. And I also talked to Ilda. Ilda and I have talked a couple of times and about some of the things we've seen in our history. I'm an old case manager by training and also designed a care transition risk assessment tool. So these kind of stood out to me. And one of the primary things that we see in a lot of these cases is there was no real identified responsible practitioner for the patient. It was a little bit ambiguous who was taking the lead in caring for these patients. And now you often hear who's the captain of the ship. So we really emphasize that to be that patient advocate, if you're the primary care provider, you're the captain of the ship, to make sure you know what's going on around that patient, because it does have a huge impact. Oftentimes they're referred to specialists, outpatient centers. Somebody needs to be quarterbacking and understand everything that's going on, and whether you're having that in team meetings, however that looks in your particular practice, but be the captain of the ship. And I know Ilda agrees with that, and she's seen that on numerous occasions. And then also educating the staff you have in your practice about the importance of follow-up and having a really streamlined process for communicating to your patients in a way that they can understand and in a way that they can access. A lot of times now we do have access to information on our personal portals within the healthcare record. Some folks don't even know about that, or they don't have access to that. So making sure that you're championing that patient. Another thing we talk a lot about is data. Knowing who your high-risk patients are. Clearly, you can't have every single patient in your practice or your organization be followed to the level that is, top. But there are patients that have issues that that you can identify, that are those that tend to return to the emergency department, those that tend to return to the hospital, those that go home and inevitably have trouble and are really struggling. So identify who those high-risk patients are. I know, Ilda, we talked a lot about that risk predictive modeling that you have used in your past, and I just absolutely think it's fantastic. And it's a way to identify those patients that have a tendency, and almost without fault, that have a tendency to have problems and be readmitted and come back again and again. And those are your high-risk patients. So how do you focus on those? And there's a lot of different tools you can use out there. You can also assess for the social determinants of health. I know there are surveys that you can ask 8 questions and determine how folks are doing at home and how likely they are to have problems. And sometimes you really have to dig deep. Patients don't necessarily let you know if they're struggling financially, if they're struggling with behavioral health issues. So really looking at those issues that put them at risk for having bad outcomes, or not understanding, or not being able to follow up with their care providers. We've seen it over and over and again where people are underinsured. They have a little bit of insurance, but they don't have enough to pay for medications. And as we've seen in our data, medications cause a lot of issues with transitions. Either they're not taken properly, maybe they aren't able to afford them, maybe they're just taking them once or twice a week because they want to spread them out. But really understanding what's going on with those patients at home is very, very important. So that's one thing I wanted to emphasize. We also really stress the importance of involving the patients in the clinical decisions and in the care process. They're actually a key member of the care team, as are their families and their caregivers. If you can involve someone from their family, if that's okay with them, I want to make sure that I stress that, but having that coach with them that can help them when they go home, that can ask questions that they may not be capable of asking at the time due to their illness or their capacity, whatever that may be, but really including someone there to help them when they go home. I know it occurs really naturally to myself. I know for Ilda and Bob, we've had these conversations about, we're very much about being advocates for our loved ones having had or having elderly parents. And a lot of folks don't have the level of understanding that we do. So making sure you're really connecting and speaking to these patients and their families in a way that they can understand, and in a way that will facilitate them once they leave if they need to call you back or have questions. And then another thing I thought about is partnering with agencies within your community. Sometimes in small office practices or even in large office practices, you discharge patients, you don't know what you don't know about what's available to them after their discharge. So really digging in and understanding what kind of help is out there for you and your patients once they go home, to keep them at home. I know there are different types of services in many different communities that address behavioral health issues, maybe financial issues. Anytime you have these complex patients, there's usually a number of things that are impacting their ability to stay home safely and not return to the hospital or have an adverse event once they get home from not understanding. So know what's available in your communities and reach out to them. Also, when we talk about, and I mentioned this under data, when we talk about data, a lot of times if you're not data savvy, or if you don't have a lot of data availability within your practice, sometimes we ask, well, where are we going to get this information? Ilda made a really good point when we had our discussion about reaching out to the insurance carriers. They have more information than you could possibly imagine. And I mean the health insurance carriers. They know so many things about your patients, about demographics in your area, about what's going on. So ask them what data they have available to help you with your patients. And I know Ilda, you talked about using that a lot. Look at your claims data. Yeah. Look at your claims data. We can send claims data. You guys that have us as your provider coverage, we have data that you can use on your loss runs. Look at it. Who are your patients? What's happening? Look at the incidents that have actually occurred and go backwards from there and kind of say, where did we fail? What happened here? Let's look at the situation in a broader perspective. And then you may not be able to help that patient, but you can apply those principles that you've learned from examining that error or that issue to other patients in your practice, and maybe plug a hole that you may not have known that was there. And I know when we were doing this paper, we were being helped by an editor, and one of her questions was, should we focus on a particular method to improve care transitions? Because there's so many out there. Should we just advocate some method of application to improve these transition? And my thought was, no, not necessarily, because every organization, and I know Ilda and Bob would agree, is slightly different. You have your slightly different risks, you have slightly different issues within your communities. So look at these different improvement methodologies and find the one that fits your organization and your patient population and your community setting. Are you rural? Are you urban? Do you have a primarily Medicaid population? And look at that and really study it. And then really, I think the one thing in terms of improvement that I would recommend is start somewhere. you don't necessarily have to solve the world's problems, but start somewhere to look at your processes. If you know you have an issue with behavioral health patients, for instance, and we all know that behavioral health patients also have medical conditions. So look at that and start somewhere, start small, maximize the tools you have to work with your highest risk population so that you don't have so much coming at you from a performance improvement standpoint. And utilize that electronic medical record. Utilize it how it's designed. I know I've been in organizations where we do anything and everything we can to make it fit the way we think it should work, really designed to help in a lot of these instances. So use it as designed and use it. I know I have been in hospitals. I have been in there as a patient. I've been there with my family. I've been there as a risk consultant, where patients come in through the emergency department and the emergency room staff hasn't looked at the entire record, even though it's right there on the EMR. I know things are busy. Utilize the tools that you have. I'm kind of out of time, but I did want to circle back to Ilda because I was just absolutely fascinated by this risk predictive modeling, and I think we could talk all day about it.
Yeah.
But it's such a great way to identify where your biggest opportunities, your lowest hanging fruit, if you will,
Absolutely.
if that's what you need to focus on. So just tell us a bit. I know we're kind of out of time, and I thought I would not have enough time. So go ahead and tell us a little bit about that risk predictive modeling.
Sure, no, absolutely. So risk predictive modeling or risk score tools are out there, and often they are used by insurance carriers to look at their patient demographics and indeed assess the risk. And what's really wonderful about risk predictive modeling is that it can look at claims data. Sometimes some will go back 18 months. A good 2-year look back is always good because it predicts what's happening and what can happen with that patient member through the healthcare journey. And one of the optimal things about RPM or risk predictive modeling is based on those activities, ED utilization, hospitalizations, whether they visit their PCP's office, keep those appointments, we can actually not only look at trends, but we can look 6 months ahead and project, for example, the derailment that we may anticipate, whether it's with a member with congestive heart failure, diabetes, lots of primary diagnosis. So if that's anything that any of you are interested in, if you work with primary insurance payers, whether it's a commercial payer, even a Medicare or Medicaid-based payer in your state, I'm sure they can provide you with that data. But I know it's often something that we utilize in care management work because we can't possibly, as much as we would love to, help everyone. But if we know that there is a top 10%, top 20% of patient members who fall into this risk category, and we can help them and impact their lives, hopefully for the better, that's how we use the data to get to a better outcome for all.
Thank you. Thank you for explaining that more eloquently than I did, but I'm just fascinated by that. And I think it's a really good nugget to take away. There is a way to identify your high-risk patients if you just want to reach out and try to get it from different sources. So that's really all the time I have. It looks like we only have 10 minutes left for questions, but we're all open to questions should there be any in the Q&A.
I actually already answered one of the questions, if that's okay. There was a question about medication reconciliation. So I always recommend following the Joint Commission's regulation on medication reconciliation. I actually placed the link in the answer there. But personally, I always ask my patients to bring their medications with them. And everybody's got a little bag of medications. And having done a little bit of home health care nursing, when I've asked patients to show me their meds, and one particular patient opened up a suitcase, the largest suitcase you could find, and showed all the meds that she'd ever taken, was an eye-opener for me. But ask them straight out, what do you take the little blue pill for? What do you take the white one? Because many patients will refer to it as my little white pill, my little orange pill. And really that's a way to assess if indeed they're taking those medications appropriately, and guide them through the timing of medications. And as much as I can advocate for patients that are on polypharmacy, whether it's more than 5 medications, more than 8, make sure they have a well-organized medication box that either themselves or an expert, a loved one, can fill out for them, because often that's where medication errors can occur. I hope that helps.
That was very good. There is another question that I see here, and I'll read it. ED physicians often call specialty consultants for treatment advice and to facilitate transition of care for further outpatient treatment and IP treatment. Is there increased liability on the ED physician if an APN or PA calls back and not the specialty physician, and then gives the ED physician direction? Well, I'll take a first swing at that with a somewhat unclear answer. There might be increased liability should there be an adverse event. I mean, obviously one of the reasons why ED physicians are reaching out for these specialty consults is to get just that, the advice on the opinion of the specialist. And so, the question is the person who is then responding to that, are they qualified to give that advice? And I know there are a lot of pressures on the ED physician to move this patient, but are you getting what you're asking for? So that one is it's possible there could be increased liability. But Anne, why don't you kind of weigh in on that? Maybe Ilda has an opinion on that as well.
Well, I mean, I think I'd reiterate what you said. It really depends on what you're needing. And if you really do need to speak with a specialist, then that's who you need to talk to. I do see that a lot with the APPs covering hospital rounding and things of that nature. So it's very specific to what kind of knowledge you're seeking and if they're qualified to provide that to you. And I don't know if Ilda has anything additional to add, but that's kind of the way I would look at that in terms of risk.
Yeah, I don't really have anything else, to add, but I can't say enough. And we all try open communication. And when we're not sure, but I think one of the challenges that we have in healthcare, I know I deal with it quite often in, previous work and work today, is, we're all trying to do the best we can for the patient, right? But who's picking up the main spoon and mixing the soup? Because there's a lot of spoons in the soup. But until someone takes accountability for saying, I'm going to take the lead, I'm going to take the charge. It's the same thing when, particular concerning cases, risk cases. How many of you have been in email strings that go for days sometimes? Who eventually says, let's stop and all come together, multidisciplinary team, to have a conversation about this patient's care needs? And when we are stable in knowing what is best, then bring the patient and the family into the dialogue. So those kind of conversations need to happen with specialists as well when there are, obviously need for increased level of care.
Ilda, just one last question to you. Would you say that most providers, if you were to actually have the ability and the time to actually sit down a number of providers as a focus group, for example, which no one has time to do that, but let's just say they did. My guess is you would probably get a pretty good capture as far as the transition of care kind of moments or places that worry them the most. I mean, wouldn't you say that there's a pretty clear understanding as to which ones are most problematic? If you could just weigh in on that.
Yeah, I mean, you hit that's a key question, and I'll tell you, in my experience, when patients go inpatient to inpatient, let's say an acute hospital facility, and we know we're sending them to a skilled nursing facility, perhaps acute inpatient rehab, we trust that there's going to be experienced staff continuing to care for them. When we send patients to home with home health care services, again, experienced staff. When we send our patients out to the community, especially members that may have intricate behavioral health needs. Let's be honest, homelessness is an issue that we have in our country, behavioral health needs. And those patients aren't likely to follow up. We can tell them, we really recommend that you have a follow-up within 7 days. Nobody sees them again. What happens to those patients? I bet if I were to sit down with providers across our nation and I would ask that question, that's likely how they would answer it. It's the patient that walks out of the emergency department and we lose them. We only hope that they come back. Unfortunately, they do tend to come back with worsening symptoms. And then the problem just becomes more concerning.
Thanks, Elda. Val, do we have any more questions, or are we pretty much responded here?
I think we did. Thank you, everybody. It was a terrific conversation. Unless someone else has anything else to say, I'll just tell our guests that we will be emailing out to you in the next day or two the Coverys Care Transitions white paper, or it is available, that our speakers referenced multiple times. It is available on coverys.com in our Knowledge Center if you wanted to download that today. So again, thank you for joining us. Look for the next Vital Insights webinar in the coming months, and have a great day, everybody.
Thank you.
Thank you.
Bye.